first today?
I have a couple.
All righty.
I hope people can see an abnormal chest radiograph here of a woman who has bad lung fibrosis. So
Yes, we can see.
this led to transplantation of the lungs, and this is, we had a series of AP radiographs, and then eventually the person was able to get PA and lateral radiographs. This is post-transplant with some maybe pleural effusion or thickening here, a little scoliosis, and here's the lateral view. Okay, and then this person, I think, had some chest discomfort or some shortness of breath. And
so, David, I'm going to stop you there. What? What's that wire doing?
Well, it's kind of weird looking, isn't it?
Yeah.
I mean, one of it's just a sternotomy wire because of the scoliosis. Things are kind of rotated.
Okay.
If we go back to the frontal, you can see that everything's kind of cocked off to the side. So maybe it's just overlapping because of the scoliosis. It appears to go too far posteriorly.
Okay.
So, but here's a CT scan. And once again, I'll have to review what the indication for the CT was. But, you know, Jeff, you were really onto something. So here's that wire. And this is not the course that you would want for your wire. You can see this overlaps into the right ventricle. Now, it's bizarre because it doesn't loop around to the other side of the sternotomy incision. So normally these wires loop from right to left. This one seems to loop, you know, from left to left, but it takes a big bite out of RV and RA maybe. So this wire was not what they desired. You know, I had blown by this a couple times on lateral view. Just, it's not something I was looking for and not very alert to. The only, you know, recovery I have from my ego from that sort of thing is that other people missed it too, but that's pretty puny excuse. So I did not appreciate what Jeff instantly saw, which was that wire was taking too deep a posterior bite. So at this point, I think this was just discovered or really identified this week, and so I think they will probably want to remove this, but I don't know whether they would do it closed or do it in the OR. I mean, it's looks like a potential bleeding problem. So not the course of a sternotomy wire that you would want in your chest. And I should show it to you on the sagittals. This makes the case pretty well. So it seems to loop from top to bottom rather than side to side. It's a strange configuration. Nothing that they wanted to do, I'm sure. Okay, this woman recently gave birth, a young woman, and she has this bizarre elongated sausage-like thing in her left lung. Let's see if we see it on lateral view. Yeah, it's sitting up here. So I think that's completely strange looking. So it was visible there a couple years before. This is 2 years earlier, I think. It's there. It's harder to appreciate because of the rotation and the low volume and the atelectasis around it. So any clues? I mean, it's probably not a malignancy given how well defined it is and how stable it is over a couple of years, 2020 to 2022. What do you think?
Could be spleen.
Do you have any dilated vessels about it, related to it?
Here's a vessel.
No,
Is that abnormal?
can't tell.
Okay.
Don't know.
But you guys are awesome because indeed this is an AVM, and the feeding artery is not that impressive, nor is the vein, but there you go. So it's an AVM, and there were a couple of others, and it turns out they didn't have this in the obstetric history until it was identified radiographically, and then suddenly there was a lot of talk about known hereditary telangiectasia. So this is hemorrhagic HHT, hemorrhagic hereditary telangiectasia. And I don't know about physical findings. I'll look them up to see if there were circumoral lesions and things like that. Now, there are a few other suspicious things in the lung, nothing that's slammed down for sure, but here's an enhancing vessel out here next to the pleura. So this doesn't have a clear central connection, but you know, the central connections to this big lesion on the left weren't that clear either. So it's possible that these are some other potential lesions that can emerge later on, including this thing. Now, this woman has some bad habits, including intravenous drug abuse, and that's going to be a particular problem for her, because when you have an AVM like this, you lose the filtration function of the lung, and bits of injected debris could pass through this thing and get into systemic circulation and cause strokes or renal infarcts. And infectious debris could cause abscesses in brain or kidneys. So you know, particularly you've got hereditary hemorrhagic telangiectasia, you do not want to be injecting drugs. Probably don't want to inject drugs anyway, if you really think about it. Okay, so HHT, turns out it was known, but wasn't on the current radar until it was picked up radiographically.
Nice.
And here's a woman who had this radiograph back in 2013, I think, with clear lungs, a little scoliosis, normal heart size. And then a few years later, this is part of screening B reading thing that I do for the Hanford cleanup. Now there's a little blob down here in the anterior cardiophrenic angle. And then with time, we advanced another 4 years to the current radiograph, and you can see that this thing has gotten bigger. So the things that live down here are, there's some diaphragmatic nodes, there's mediastinal fat. Mediastinal fat usually does not have a convex border to it. There is Morgagni hernia, which can have a nice convex border and could be fat composition, but fat coming from the abdomen rather than the chest. Here it is on lateral view. You can see it sitting up here, and previously it was not so impressive. And it does seem to be maybe tucked into the fissure. Fat can do this. Pericardial cyst can do that. This is fairly rounded here, and it's fairly rounded on the lateral view. So that rounding is good for Morgagni hernia. I think that's the best explanation for this. So it turns out that she had a CT scan. So CT scan is definitive in these cases. It will distinguish lymph nodes from fat. It'll tell you where the fat is coming from, whether it's native mediastinal fat or herniated Morgagni fat. And it'll tell you whether it's water attenuation for pericardial cyst. And once again, CT pulls through, and it's a low attenuation, uniform, very thin wall, imperceptible wall. So this is a pericardial cyst that had slowly enlarged over several years. I was expecting Morgagni hernia in view of the convexity and the growth. Now, pericardial cysts are flaccid cysts. There's no tension in this wall because it's so thin, unlike a bronchogenic cyst, which tends to have a fairly hefty wall. It'll form a sphere because of tension in the wall. Pericardial cysts are floppy, and they often get sucked into fissures. So that's why this one is being sucked into the minor fissure here, sorry, in the major fissure by the negative pleural pressure. So this is covered by parietal pleura. So parietal pleura is very stretchy. It's easy to pick it up off the chest wall. And here's an example of how it picked up by the negative pleural pressure, sucked into fissure. So parietal pleura is very, stretchy. So pericardial cyst as the cause of an anterior cardiophrenic angle mass. I was expecting Morgagni hernia, but this was pericardial cyst, which is definitely on the list. Okay, guys.
Very nice. Okay, who would like to go next?
I can go, Jeff, anytime.
All right. And David, I have a companion case to your transplant case I'll show when I go.
Okay.
It jogged my memory.
All right, let me start with this one. This person is without symptoms. And I'm going to tell you a little bit more about the patient in a moment. But for folks viewing the video online, trainees, take a look at the chest. And if initially you don't see any opacities, that's exactly right. There aren't any. But if you look at the vessels, they are certainly odd. So particularly up here, where there don't seem to be any, or the ones that are present in the upper lobes in particular are small, irregularly small, and they seem to, at least in terms of their visibility, stop about here. So the lungs up here look empty of vessels, that is. So the vessels are odd. So I saw that and I thought, well, I don't know what that is. Asymptomatic. We've seen a few and shown a few cases, most recently by David in a patient with the chronic lung disease of prematurity, BPD. We'd like to get the history of this patient to see if she was potentially a preemie, which she apparently was not. So, you know, what to call this? In the absence of a diagnosis, call it dysmorphogenic lung, just to say it's abnormal, but I don't know what it is. And it turns out that this patient has prune belly syndrome. So can we potentially associate this with prune belly syndrome? So I've looked for some articles. I did find a really nice article in the pediatric literature, as you can see here, pulmonary complications of abdominal wall defects. And one of the entities described here with really nice images is prune belly syndrome. And speculatively, perhaps it's due to the fact that patients with prune belly syndrome may have oligohydramnios, and that may affect the development of the lungs in terms of hypoplasia. So here you see sort of a description of things that one may see with prune belly syndrome, hypoplasia, episodes of atelectasis and pneumonia, and so on and so forth. So I think that's a reasonable supposition, perhaps. I can't think of any other way to describe this. And I actually forgot to show you the CT. But, you know, the lung, there aren't frank cysts there. Let me show you the thin cuts that I can see. Kind of just shows what the radiograph does. The lungs just don't look right. Any thoughts beyond just describing this as odd-looking lung?
Well, Howard, you said that she had a prune belly that's often diagnosed prenatally. So even if she wasn't premature, I imagine she would have spent a sizable amount of time in the NICU, right?
I don't know.
And if she had pulmonary hypoplasia, I imagine she would have been intubated in the NICU and had not necessarily the same complications of RDS, but some of them, and probably was on a ventilator at that time.
Maybe. Look at, oh, I forgot
And the
about this.
anatomy looks funny there, Howard.
But the lower lobes look relatively small. They're odd lower lobes. Here's a cystic space. So,
Which looks like an airway.
yeah.
Yeah,
And
the
then
anatomy looked funny. When as you were scrolling, I was looking at the branching pattern.
I looked to see whether in the notes whether there was any description of prematurity in a hospital stay. I couldn't find any. They were relatively brief notes.
Because it looks like her upper lobes are very emphysematous, right? They're much more lucent than the lower lobes.
They're big. They may not actually have. Well, here's kind of an empty space there. I don't know if we should call it emphysema as such, but definitely abnormal.
I think if you throw like a Hansel unit on there, it's going to be significantly lower than the lower lobes, which look relatively compressed or non-expanded by comparison.
Yeah. Yeah, that's definitely sort of an empty space there, but it's also kind of empty here too.
So Howard, you said that
Yes.
this syndrome results in oligohydramnios. Did I catch that?
The article describes pulmonary hyperplasia in the context of prune belly, which is ascribed to oligohydramnios.
Okay, and the mechanism there is that basically the thorax is being compressed
Yeah.
in growth. Is that it?
Yeah.
Okay,
I believe so.
yeah. So I mean, those upper lungs are so abnormal. I mean, they're very scrawny vessels spread
Yes.
out. Really looks very hypoplastic up there. And then the lower lobes are not as bad, but they've got a lot of problems too, like that big lucency and stuff like that. So yeah, these lungs are really messed up.
As far as I can tell, looking at her history, which I looked at, she's never had respiratory complaints. She's in hospital for other reasons, but there's no indication that she's going to pulmonology clinic or has any. No, she may be a sedentary person and may have issues if she were to exercise, of course, perhaps, but her presentation is not a pulmonary one right now, at least.
Howard, show the upper lobes again.
Okay.
So some of the vessels are, so there's one large vessel in the left upper lobe and then a few, but some of them are scrawny. So are those the pulmonary artery, the large one, if you scroll down a little bit?
Okay.
So some of them are in the right lung. So some of them aren't scrawny. Some of them are actually large, and then a lot of them are scrawny. It's just interesting.
Look how scrawny the whole lower lobes are, and
Right.
I just go into a small volume lower lobe like that, as
Yeah.
well as other observations. And even down here, this seems to be a rather empty area of lung.
Yeah, the vessels there. Very interesting.
Yeah,
But
this lobe is taken up with space.
But that vessel right where your mouse is not affected. I mean, that's right lower down. Or if you more posteriorly, I meant. Like right in that region, there's a large vessel.
Yeah, the veins are quite large. The arteries are same caliber as the airways, but I mean, clearly these are not normally developed lungs, but I presume she just is young and has enough functioning alveoli that she's not symptomatic.
Yeah.
But you get the sense it's sort of like a hypoplasia and just sort of underdeveloped lung, and it would explain why the anatomy is a little funny, and the vessels are, and the lungs just look like there's less tissue per unit volume.
Yes.
Yeah, something like that, particularly up here, of course.
But clearly they're functional, and she doesn't have findings suggesting chronic hypoxia, or which you would pick up clinically.
And no pulmonary hypertension there, right? I didn't look at the main pulmonary artery.
Howard, it's interesting. It looks like she has a intubation stenosis that's mild. I wonder if she was on a ventilator at birth, or it had something right there.
Oh, let's have a look at the coronal. I don't think I noticed that.
It's very subtle. But it looks like a pretty classic intubation stenosis.
Could be a bit of narrowing here. Okay, it's not as narrow as that. It's
You
a
see
little wider.
asymmetric, but
Does the left lung also look smaller to you guys?
yeah, it's a little small. Yeah, those lower lobes just are really small. But the scoliosis may. Oh, that's an interesting case.
Yeah, it is, isn't it? Yeah. Okay, let me show you this. This is mostly for trainees, so I won't spend too much time, but there's a lesson to be learned here in terms of how to image and then having to describe such extensive abnormalities in a hemithorax. So let's say you were reading this without contrast and you're trying to decide what's in the pleural space. Obviously, lots in the pleural space, but what about the lungs? They've compressed. What's in the pleural space? Coming down here, what's in lung? What's in pleural space? It can be really hard. And you could say, okay, this is lung here. This is pleural fluid. Is the lung more than just compressed and atelectatic? What's in the lung? it can be really hard. And usually whenever I can, and they're imaging what they think is an infected chest, pleural space, and so on, I personally always kind of try to insist on contrast medium. And I think that one of the lessons here with contrast medium is look how much we can diagnose in terms of how abnormal the lung is. So we have pleural space abnormality, but we have a tremendous amount of necrotizing infection here and abscesses and confluent abscesses in there. So whenever you can, really insist on folks, even if they want to say, oh, we just want to know how much fluid there is, we want to know where the fluid is, do we tap that and so on, fine, we can do that. But we really want to diagnose this. So this is strep anginosus, necrotizing pneumonia, and pleural fluid. So very impressive, and how much easier it is to evaluate the lung with contrast medium. Do you folks see a lot in a general sense, a lot of imaging of the chest in patients with pleural fluid without contrast, and they say rule out infection or something like that?
Yeah, not uncommonly. A lot of times they're critically ill patients in the ICU with renal failure or kidney injury.
May have that.
Yeah, I mean, the contrast can definitely be helpful. Then there's been some papers on that, but at the same time, short of, fluid sampling usually is sufficient to diagnose, at least in the pleural space. But sometimes you see little areas of gas or something in the lung that doesn't look right that suggests it's infected. But yeah, this is one of the times when having contrast actually can be quite helpful. But I find most of the patients we image are so ill that contrast really isn't an option for them at the time.
Yeah, that may be the case. It's a trade-off too. I think in a general sense, we've overestimated the harms of contrast medium, and I'm a strong advocate for that in complicated cases like this, for example, myself. It makes it so much easier to interpret, especially residents too. Let me show you this one, which is also an interesting case for trainees. So this is a person that has emphysema and pneumonia. So if you look at the scout radiograph before we even start, we can say, okay, there's a lot of opacity in the left upper lobe. Here, maybe consolidated lung, fine. Now, we can see that this is a process in very emphysematous lungs. And we can see the consolidation, and we can see it here too. But more than that too, I want to show you, and I go to this one, which I'll put alongside it, and try to separate these two from each other. I just want to move things aside here so I can stop the synchronization, which I'm just trying to get the GoToMeeting controls out of the way. Oh, gee, let me try something else. It's weird. I don't want that to happen. So this is 8:30, and then this is 5 days later. I can't get to the controls, I'm afraid. Let me just scroll through this one. On this exam here, if we look at the background and look at the lungs, I think this is a really great example of what lung edema looks like when it's located in emphysematous lungs. So away from the areas of consolidation, we have this appearance where we have holes, but in between the holes, the lung tissue is too opaque. And here we see that same kind of phenomenon. And in looking at this further, we can see, and I don't have the comparison up at the moment, but pleural effusions have developed, as well as very substantial subcutaneous soft tissue edema. So at this point in time, we have findings consistent with hypervolemic fluid overload lung edema, and the edema is located in emphysematous lungs. So I really wish I could stop that scrolling. But again, just look at the background lungs here and the holes. which when that lung is wet, here looks like this. So emphysema can substantially affect the appearance of lung edema. And I think this is a great example of that. Do you guys agree with that?
Yeah, I think the nice layering, gravitational layering is a helpful finding. Although I think you still have to think about potentially infection mixed in there just with the degree of consolidated lung.
Right. So I think this lung is, I do think there's a lot of interstitial edema, and the areas of the lung that don't have capillaries don't get wet, but the emphysema can substantially influence what lung edema looks like, particularly when it's this extensive. And this undoubtedly is a person that developed over time the findings of fluid overload and effusions and generalized soft tissue edema. You can just see how tremendous soft tissue edema that has developed. Okay, those are my cases, Jeff.
All right, thanks, Howard. Okay, let's see. Peter, you want to go next?
Sure, I only have 2.
All right, let's.
Okay, that's fine. So I'm not 100% sure if you're doing this.
Can you guys see the screen?
Yep.
Yep.
Yes, I only have 2, and they were shared to me by my colleagues. This one is a patient with neurofibromatosis, NF1. And interesting finding here is it's a vascular case, so CTA, chest, abdomen, pelvis, and it's just this marked stenosis of the suprarenal abdominal aorta there. You can see it, and then she required a bypass.
Mm-hmm.
So nice example, the most severe one I've seen of NF1 causing this aortic stenosis in the abdominal aorta. It's kind of a coarctation. The differential for this is in young patients is mid-aortic syndrome, which is kind of the idiopathic disease, and then Williams syndrome and Takayasu and NF1. If you look at her mediastinum, she also has, and we've shown recently a few cases of this, and I've been seeing it more and more as I see NF1 patients. See this soft tissue abnormality here. So those are plexiform neurofibromas along the course of the vagus nerve, or possibly other nerves that are coming down the phrenic and other nerves that are here, and then along the by the sympathetic chains there.
Yeah, very, very interesting case.
And then this one was a very interesting case to us. I think it was a good diagnostic call also by my colleague Naeem. So we'll start off with what they looked like in July. So they got a coronary angiogram and CTA angiogram in July, and the lungs are nothing remarkable really. And then I'll show the scan from.
Yeah, so I called the
Let's see if I can set this up. Yeah, so on the right is the original July scan, and on the left is October 6th. So it's very scattered ground glass nodules, very ill-defined, and so correctly it was assumed. I'm not sure if the patient they might have presented with sepsis also, but the good differential is given for vasculitis and also malignant metastatic hemorrhagic metastatic disease was included. in the differential. And so this is just a few days later, just kind of the same thing. But you can see some of the ground glass opacities have changed a little bit.
What's the time between the scans?
So let's get rid of the first one. So these are just 8 days apart. So you can see there's some change. So I mean, yeah. So pulmonary hemorrhage makes sense, just given the change. So, but there was a delay in the workup of this. I'm not sure if the patient just didn't show up. So they came back in December, and this is what they looked like in December. December 7th, and so this is rapidly progressing. I'm not sure what's loading right now. Okay. And so that was December 7th, and I'm going to show. This is December. This is 9 days later. So very aggressive process, large masses, malignant effusions. This was biopsied, and it was angiosarcoma. This is angiosarcoma, and the patient was started on antibiotics and has started to improve.
Wow. And the breast findings presumably represent a consequence of central venous obstruction, maybe?
Most likely, yeah, because it just seems like diffuse edema throughout the breast and right chest. Yeah. So responding to chemo pretty well, improving. But I guess it was just that big delay between October and December that allowed it to kind of get out of control. But it
And
just,
the one in October, again, just show that again, because those
Yeah.
are like glass attenuating opacities rather than solid ones.
Yeah.
So
ground glass opacities that were completely new since July. So just a good reminder that that's something to consider for something like this is hemorrhagic Mets, which was a good call by my colleague.
Yeah, it looks like COVID too.
You're right.
Yeah.
Yeah.
the
So
more you, yeah,
It's
the more you
interesting.
scroll, the more.
We use the term hemorrhagic Mets, but I think it's probably not quite the case. I think it's Mets that have varying degrees of neovascularity, because it would be odd that they all are bleeding at once. And if you've ever followed them up, sometimes they look very similar.
well, but there is a follow-up here. So there's
Oh, no, I'm saying they can bleed, but the fact that all of them
Yeah.
are bleeding at once to me is kind of
Right.
a little off. But we had a similar case of a sort of disseminated or diffuse angiosarcoma in the lungs that looked like infection. It looked like multifocal consolidation. I'll see if I can find it and present it. But that's what happened. There was sort of a rapid change, and because they intermittently bleed, it can be really hard to pin down the diagnosis, especially if you're not thinking about it, because it's not one you see very often without a known primary. But yeah, I think you're absolutely right though. For sort of halo signs, it's definitely the differential. I've seen testicular choriocarcinoma do that as well. And when they gave chemo, the ground glass component around it went away. And to me, that's sort of just the vascular nature of the tumor, not necessarily that it's actively bleeding. That's why I don't like the term hemorrhagic Met.
Yeah.
That makes sense.
But yeah, no, your point is well made though. That's a great case. Tough diagnosis.
Yeah. Oh, impressive.
Did you see the primary site?
I don't think we know what the primary site is. Presumably, it's one of the lung vessels, but because I don't think they had extra thoracic findings really, as far as I remember on this case.
Yeah.
Oh.
Yeah. That's all I have, guys.
All right, great, thank you. All right, so David, I'm going to show my companion case to your case. So you should see a post-transplant radiograph.
Good.
Yeah, so this is a patient who had has a port in because they had cystic fibrosis, and you can see there are 2 cyclage wires here. And in David's case, there was also a plate, and I've noticed our surgeons have pretty much been putting plates on everyone lately. So here was the lateral view accompanying that, and you can see a very similar funny orientation, and there is a little bit of rotation in there as well. You can see some of the rib projecting here, so it may seem a little deep, not quite as deep as David's. So this was the radiograph. I'll put them up. These are just 3 months apart. So this was the follow-up, and you can see that this wire here is fractured, and there's now a fragment down here, and they can break and they can migrate within the chest wall, but this is where having the lateral is more to our advantage. Let's see, I want to make this one go away. And you can see that this fragment here, this is the part that was deep there, is still poking into the chest. So this one has dropped down, presumably within the chest cavity. Now let me show the CT here. So this is the CT scan that was done about a week after the second radiograph. And there we can see the fractured wire, and it is protruding towards the pericardium right up against the main pulmonary artery, RVOT area. But this other wire is sitting down here in the right ventricle. So I don't know if my guess is it broke off and dropped in and just got lodged in there. But this was a case from many, many years ago, and David's case jogged my memory. That's maybe one of the reasons I recognized it. I thought we had a case at some point. So that's a case of a migrated wire, and I can't remember. I don't know what they did with that. It's like I said, it's a really old case. All right. This is just a nice case here and has a good radiograph. So this is a young person who was referred to us and has an abnormal radiograph, and you can see that there's a difference in lung caliber. Lung size. The right lung is small. The vessels are rather attenuated. And if I zoom up a little bit, you can see that there is some thickening along the fissure, a little bit of volume loss in there. Here's the lateral radiograph, and we see there's a lot of soft tissue around the hilum, especially in that infrahilar region there. So I will show you a CT scan at this point. And this is an older scan, but had a good contrast bolus. And the first thing you might notice is there's some big vessels right here, and these are bronchial arteries. So hypertrophied bronchial arteries should always get you interested in something, because it usually means there's a long-standing process. And then we can see there's this soft tissue here around the bronchus intermedius, and some calcifications at the hilum as well as in the subchorial space. And then you'll notice immediately there's narrowing of the airways. So other things we got to look for, the pulmonary arteries. Here's the right pulmonary artery, and you can see it comes to a point. So the upper lobe pulmonary artery seems to be out or severely narrowed. The interlobar is narrowed, and then the lower lobe pulmonary artery is narrowed, and the middle lobe, it seems to be out as well. But if we go distally, you'll see there is contrast in those pulmonary arteries. So there may be some contrast getting through, or alternatively, there's enough bronchial arterial collateral shunting that there is some flow in there, and there's calcification down there. And David's going to ask me to show the spleen. There is no calcium in there, but still, this is pretty classic fibrosing mediastinitis. And I want to show some other findings of it, presumably from histo. That's the most common cause in that appearance. We see septal lines from the veno-lymphatic obstruction. It's not just the veins, but also the lymphatics. And then if we look carefully along the pleural surface, you can see that it's pretty shaggy in some areas, and I suspect these are transpleural collaterals. You can see these veins go right to the pleural surface, so we normally don't see vessels that close to the chest wall. So that should also be an indicator of that. There's middle lobe volume loss from both airway, and then that's probably one of the primary histo lesions right there. Just talking about that bronchial artery circulation, so here is the ventilation image. And you can see it was about 2/3 to the left and 1/3 to the right. So there's still some air getting into all lobes of the right lung. But if you go to the perfusion images, you'll see it was about less than 1%. I cropped out the quantification because it had some patient information, but you can see there's normal perfusion in the left lung, and there's no visible perfusion at this scaling to the right lung. Yet we see contrast going down there. So I suspect that it's all bronchial arterial collateral flow. And really, this is a non-functional lung with regards to ventilation, perfusion, ventilation matching. So just a nice case of fibrosing mediastinitis.
Yeah. Gosh.
That's a beautiful one.
So this is a fun case. So I showed a case a while back of a patient with SVC obstruction who had, let me show the sagittals, who had what looked like sclerotic bone lesions, but it was all related to venous collateral flow. And so here's another example. This patient has a history of pancreatic cancer and has, you can see all these collaterals in the mediastinum. I won't go into all that, but you can see these really nice big collateral veins draining along the spine. And if you look in the upper portions of the spine, you can see there are some denser areas in there. You can make out one here as well. And then this patient had a follow-up CT. Let me get these on the bone windows here. There we go. Get this out of the way. Let me unlink them. And on this follow-up, what's interesting is you can see there those collateral channels even are more conspicuous. You can see them, and I'll show them in action in a minute. But I do want to point out this bone here has changed. And if you look at it in retrospect, it looks a little sclerotic in that area. It has become more sclerotic. And then there's this little lucency that has formed in it. So I'm going to go back to the axials now. So let's close that one out. So this is the original, and then I'll bring up the comparison, get these on bone window again. So there we can see all this really nice collateral flow coming into the bone through all these venous channels. And here we are again on the follow-up scan. You can see all of these collateral vessels. But when we get down, and then there's a really nice example of one going in along the neuroforamen into the venous plexus there. But as we get down, this is the bone in question. And this is not a normal looking bone. I'll go a little lower to about the same level. So it has become more sclerotic. So this is a case, and this is a bone met. The patient had some bone mets elsewhere, probably more sclerotic because of treatment effect. Because if you look at that lucency in it, it's pretty well corticated, but there is a breakthrough right there. And then looking at the old scan, you can sort of hallucinate a little lucent lesion right there. So it's unclear if it's treatment effect or not, but this is an example of pseudo bone mets with a real bone met right below it. So, but just be aware of this phenomenon of these pseudo bone mets, because I know we've talked about them before here, and seeing that this kind of, and it seems to affect the the vertebral bodies more often. That's because that's where the level of the obstruction and the collateral routes are. You can see the brachiocephalic vein here is a thread. The right brachiocephalic is a thread. The SVC is mostly out, and then it reconstitutes through the azygous vein. And then once you get below the level of the obstruction, you lose that collateral pathway.
So Jeff, what's the mechanism? Why does these distended veins and this obstruction and this high pressure lead to bone sclerosis? What's going on?
Well, it doesn't lead to bone sclerosis. It's pseudosclerosis. It's just contrast in the venous channels of the bones. What this is a real metastasis here.
Okay, but so you're saying that what we're seeing is contrast in the bone rather than
this denser area here is contrast.
Yeah.
Here, I'll show in the axial again. You can see.
So it's pseudosclerosis then.
It's pseudosclerosis, right? So these are venous channels here. So you can even see follow the vessels in and out.
Mm-hmm.
That's a pseudometastasis. And even here, you can see these areas right here all link up to these little tiny veins that are going in and out of the bone. But then if you go to the level below, you don't see those channels anymore. Notice how clean it is around the margin, but the bone is sclerotic there. So that's actually tumor. Whereas this stuff is contrast. Does that answer your question?
Don't call bone sclerosis without, if there's contrast and there's venous obstruction. Got it.
Yeah.
Okay.
So a case of pseudomets with mets. This is a cool case. One of my colleagues asked me about the other day, and I didn't know what to call it. I had seen a case before, I forgot it, but we were chatting about this with some of our other people, and this is a patient that this was just I can't remember why it was a PE study, and what was noticed was that let me change the window a little bit, that the SVC got really narrow just above the junction. It's kind of being squeezed. And you'll see there's this low attenuation tissue around it. And you see it's fat attenuation. I'm going to show a non-con that was done at a different time just because it makes it easier to see the different tissues. But you can see there's fat, so it looks like fat around the SVC sort of extending towards it's a little higher than the fossa ovalis. So there's the fossa ovalis. So we've seen cases of lipomatous hypertrophy of the intraatrial septum. But you'll also notice that there's a lot of fat in the RV wall here. There's a lot of epicardial fat deep to the pericardium. So there's just a lot of lipomatosis in and around the heart there. And so, and here's just a coronal reformat showing that narrowing there. So there is an entity called right atrial lipomatosis, and Peter, you may know a lot about this because I know you do some cardiac imaging. It's thought to be a benign process. There are case reports of patients with lipomas there compressing the SVC, but this is one case I found here. It was a cardiac surgery image, but you can see the narrowing of the SVC. Now they showed an echo, but this was more of a discrete lipoma, and they actually had resected this one. But I've seen this a few times. I just never thought much, but then I went back and looked through my files and found a case that I did archive a few years ago of just this fat narrowing. So it seems not to cause an SVC syndrome, so there's really no reason to do anything about it. But just be aware it exists. This case is just more exuberant in that there's more fat also in the wall of the right ventricle, which can be a normal finding. And people talked about that with arrhythmogenic right ventricular dysplasia, although it's not a specific finding. We see fat in the heart not infrequently, it seems like. But I don't know, Peter, if you have any comments about this.
Yeah, I've seen the lipomatosis. I haven't noticed before the stenosis of the SVC, but that's cool. Can you show that again? Was it circumferentially squeezing it, or was it pushing it from one side?
You know, it kind of looks like it was a little bit of both, but there's clearly favor sort of from the inside and a more normal outside. But then as you go lower down, it sort of circumscribes it right there.
Okay. Yeah, I'll be on the lookout for these. I haven't seen that.
I think that's the crista terminalis or something there, right? Just another fatty structure that can enlarge.
That. Yeah, I guess this extends into that. Yeah, right there. It's just really fatty.
Yeah.
But this is like it's not just that area. It's like the whole. It's a part of the intraatrial septum and even part of the wall of the heart there. But yeah, this was
like this is compared to the one you showed just before this. There's no venous collaterals, right? Like,
right.
There's no secondary sign of increased pressure.
Right. Like it's a pristine mediastinum here.
Yes.
Yeah, so it's an incidental finding, and I know I've seen it before. I just never thought much of it because we see it at the IVC where they used to describe that as a lipoma, which is really just some fat at the down low. People, I remember as a resident, you learned about this. Sometimes you get that little fat that would come up and push on the IVC, but it never caused obstruction.
Yeah, I see this pretty often in the right atrium. It's also often seen in people who've had like chronic indwelling catheters.
Mm-hmm.
Just I think the stats showed a case like maybe like there's some irritation there.
Okay, and this is my last case. So this is a patient with rheumatoid arthritis who has emphysema and also has some RA associated chronic lung disease. And we happen to have paired inspiratory expiratory images on this patient, which we don't always have because we don't always need them. But in this case, I forgot why we did expiratory, but anyway. And what was really cool, and so this is the inspiratory, this is the expiratory, is you can see there's quite a bit of confluent emphysema in the upper lobes. And this patient was a cigarette smoker, pretty extensive. And as we go to the lower lobes, you'll see there is fibrosis or there's some fine reticulation. And then there's these sort of thicker walled cystic spaces with some internal architecture. And we've talked about this on this webinar. What do we call this? Is this airspace expansion with fibrosis, smoking related stuff? And I've always thought of this as, at least what my understanding is, these are emphysematous spaces, but there's fibrosis in what's left of the alveolar walls. And they have a tendency to form in the posterior lower lobes. But what was really cool in this patient, you can see there's an air cyst there, is with the expiratory images, these collapse down all the way. And that caught my attention because some cystic lung diseases, the cyst can change caliber or size with expiration. Emphysema doesn't typically change that much. And if you notice, if we look at the emphysematous spaces, yes, there is some volume loss, but not as much. But when we go down, these spaces are gone all the way. So there's a couple of reasons, and I already reached out to some of you to talk about this. But one explanation is that these are that the airways that communicate with these spaces, the small airways, are intact, which would allow air to get out or in. And then, whereas the emphysematous spaces, those small airways may already be diseased, and so there's just sort of diffuse air trapping up there. There's other possibilities. Is you have more lung down here. You have the weight of the lung, so it's able to empty out more. And I think, David, you may have raised a few other points as well, but it's just kind of interesting. I've seen these spaces change a little bit, but I've never seen them collapse all the way. Curious what other.
Yeah. Jeff, I've seen them change dramatically in going from supine to prone, because when you shift the atelectasis, if you've got some emphysema in the bases, you can stretch it out and then you can collapse it dramatically, changing position. So I think it's a flaccid space. It's very easy to compress it. It has no elastic recoil within it, so it's stretched open passively, and then as soon as you release the stretch around it, it just collapses. So I think gravity could cause this, and in your case, expiration caused by relaxing the elastic recoil around it.
Yeah.
It's just
There
interesting.
may be very compliant cystic spaces that are not associated with pressure.
Yeah.
Hypercompliant. They basically fill with air when you breathe in because they're more compliant than adjacent normal alveoli, so they preferentially fill on inspiration. Then you might get these other effects on expiration or by gravity, because the local compliance may be
I guess, and the lung around it's probably a lot more normal, and so but it tells you that these spaces are in communication. They're not walled off cystic spaces that live on their own, because that air's got to go somewhere. So yeah, I just thought that was kind of a cool thing, and not something we usually don't do expiratory images. I think this was because it was their initial scan or something on a lot of these COPD type RA patients, unless there's a good reason. So alrighty, well, it's almost the hour. Great cases this week, and I'll talk to everybody next week.
Thanks, everyone.
Bye-bye.
Thank you. Thanks, everyone.
Thanks.